Good afternoon. I'm sorry I can't be with you. I was going to reflect on some of the problems that we've been having, not just in the UK, but actually across many healthcare systems across the world, where we're seeing levels of demand increasing very rapidly, not just because our populations are growing and aging, but also because, of course, we can do more for our population. And we're also, I think, in the middle of a survival boom. But unfortunately, the people who are surviving are less fit and have fewer years of healthy life ahead of them than perhaps we would have expected with the same cohort 10 years ago. And in fact, we're seeing a fall in life expectancy in the 75 and 85 pluses. So people are getting to that age and they are heavy consumers of healthcare. And policymakers for a long time have worked out that perhaps if we can care for people in other settings and in different ways, there are opportunities not just do better things for patients, but maybe also we can save money and be able to absorb some of that increase in demand without some of the very high costs that are associated, particularly with hospital care. And I'm afraid the story I've got for you is slightly disappointing in that it turns out that it's both harder to do and that the savings are more elusive than perhaps we and the policymakers had hoped. But I guess many of you already suspected that. Just to put this in context from the UK, this is a government report which talked about the importance of creating networks of care and integrated care across systems, and it's from the 1920s. And I'm sorry to tell you that we're still some way off. The language has changed slightly. We now write in shorter sentences, but the sentiments remain the same, and we're still some way. So we had a look at the evidence across 5 areas. We looked at elective care, changes in the emergency care pathway. We looked at some time-limited interventions that people have been doing to try and avoid admission or to facilitate discharge from hospital. We looked at the very popular area of looking at segmenting populations to target the at-risk groups, particularly including end-of-life care and support people in nursing homes. And then we've had a look at the what you can do for support for patients who care for themselves and how we can help people access community resources. So I'm hoping you can see my slides, or whoever's operating them and has caught up with the one labelled 5 main areas, and if so, we'll move on and spend a bit of time on this slide. And the good news is there is quite a lot of positive evidence that we can make a difference both to patients and to some extent to costs through carefully executed and well-planned interventions. I'll pick a few of these out. Remote monitoring of people with certain long-term conditions. Rather interestingly here, not all long-term conditions are amenable to this. It does seem that heart failure, for example, does very well with getting patients to weigh themselves and report their symptoms. And now that the technology can be incorporated into smartphones rather than into bespoke, rather expensive home-based equipment, the cost effectiveness of this starts to look quite good. But for chronic obstructive airways disease, for example, this doesn't seem to be as effective, and it may be something to do with the fact that the onset of crises in heart failure are perhaps slower and easier to detect, and that the positive predictive value of the signs and symptoms that are collected by the remote monitoring is rather more reliable than it is for COPD. But it's by no means the case that getting people to monitor their long-term conditions necessarily gets us better at intervening early. An interesting problem in the management of diabetes is turning people who are otherwise feeling healthy and quite at ease with themselves into people who are obsessed with measuring their symptoms and have a twice daily reminder of their condition, and indeed of the fate that they may remember their parents suffering if they've had the same disease. So there's some downsides to focusing people. Those of you who are familiar with the work of Daniel Kahneman will remember that continually focusing on something that concerns you is not necessarily very good for you. But we have seen some nice results from that, as we have with some really well organised end-of-life care provided in community settings, particularly using social care type interventions rather than just healthcare. So advanced planning and then well organised, coordinated services with proper intervention early, and the conversations with relatives and family at an early point, so that services can be put in place rather than at the crisis point at which you're deciding whether or not the patient should be going to critical care. So again, some nice results there with some very substantial reductions in admission to hospital and days spent in the critical care unit at the end of life. So a good story there. And again, resources released, particularly in our country where the availability of critical care is a problem. Can I just check in and make sure that everyone's hearing me okay?
Yeah, the hearing is fine. It's going well.
Fantastic. Right, I shall carry on. So various types of condition-specific rehabilitation, for example, pulmonary rehabilitation for chronic obstructive airways disease and cardiac rehabilitation. Interestingly, the studies, of course, done by the proponents of the particular condition, but intriguingly, the content of quite a lot of this rehabilitation does seem to be rather common. It's not very clear that pulmonary rehabilitation is notably different in terms of what goes on from cardiac. But again, we seem to see some good results for that, as we do from a variety of targeted support for people to help to care for themselves at home. But the characteristics of the patients are important there. One area where we've seen really, really spectacular results in terms of reductions in admission to hospital in double digits is a package or a bundle of measures aimed at nursing and residential homes, care homes. And there's a collection of these. The first is medicines reviews. Can we get the average number of medications, which in many care homes in Europe is over 10 medications per person? And if you just think about the literature on what the probability of making a medication error is every time you administer one, just the reduction in number there are some benefits from. Turns out that many of these medications, probably for quite a few of the residents in these homes, have passed their usefulness. It's not clear that if you're 95 that a statin is something that is going to be of great benefit to you. And quite a lot of the medications control the side effects produced by the other medications. Advanced care planning, particularly around end of life, training the staff and letting the staff really feel that they're confident in a crisis, and providing regular ward round type activity from a general practitioner or a geriatrician has definitely had some extremely good benefits, not just in the care for the patients, but also in the relationship between the nursing homes and the hospitals, where the tussle to discharge patients, where nursing homes have a tendency not to believe the hospital who tells them that the patient is ready to return home, often through bitter experience, that those relationships are improved. Come back to this issue about relationships, because while a lot of what we're talking about here is based on technical design of programs, it turns out that the nature of the relationships underpins these is often the magic active ingredient, and why some of these models are not so easy to replicate if you just replicate the external, the technical components of them, the anatomy. You have to also get the physiology, which is often driven by the relationships. Giving primary care doctors immediate access to specialist advice in the ologies, cardiology, respiratory medicine, pediatrics, geriatrics, so that we avoid the common problem in many gatekeeping type systems that referrals go via post, or if you're very technically advanced, a fax machine, still extraordinarily common in many health systems. Another, again, a sort of theme that's emerging here is giving early access to expertise. And I'll pick on two here. One is the training of very high qualified ambulance and paramedic staff triaging patients in the community. And then to jump across to the emerging positive column, getting the most senior decision maker in the A&E, that's our abbreviation for accident and emergency, the emergency department, so that you see a senior decision maker, as opposed to a very common system in quite a few countries in which you are escalated from doctors from a low level of knowledge to a high level of knowledge until you find someone who knows something. So this you go straight to the senior decision maker. So the whole collection of things here, they have a number of aspects in common. Is that they change the point at which you intervene in the pathway. They change the seniority of the person that you perhaps tend to talk to first. They change the relationships of many of the people who work together, and they, in some cases, challenge the way that people currently practice medicine. On the emerging positive side of this, there's very good evidence that policymakers, particularly in our country, but also in others, have over-prioritized immediate access to general practice as opposed to continuity of care. Now, while for patients who've got self-limiting conditions need a blood pressure check because they're on a contraceptive pill or have perhaps just a generally healthy but have an immediate and probably time-limited problem, continuity isn't very important. For most of our heavy users of healthcare, continuity is really important, both informational and relational. So somebody who knows the context of the patient, knows what they're capable of, actually is aware that they have that strange blue tinge around their extremities, or that when they go to hospital, it's important that someone looks after the cat. These soft and quite hard to quantify bits of intelligence help inform clinical decision making, and again, hard to capture in the type of evaluations that we've done. But recently seen some very interesting quant data here, which has definitely demonstrated some very beneficial impact from seeing the same general practitioner if you have a long-term condition. Similarly, the so-called extensivist model, so a model of primary care where a geriatrician or a family doctor with a list of maybe 300 or 400 patients of the highest users, what Atul Gawande calls the hotspotting model in his New Yorker article, which I expect many of you are familiar with. Again, seems to be some emerging positive evidence here of some pretty impressive impact. The other interesting thing here is that while that seems a very generously small list size for a doctor to manage, there's a large number of other staff, health coaches, physical therapists, mental health professionals wrapped around those GPs. It's a good way of making what's becoming an increasingly scarce workforce stretch further. So that seems to be getting some benefit. I've mentioned the benefits of senior decision making in the ED, and similarly, and again, another theme here is, can you get rapid access to people for urgent specialist advice? I beg your pardon, I've missed out social prescribing. The evidence a little bit more mixed here. I think some recent studies since we did this research have come out which have cast a little bit of light on this. This is giving GPs and other primary care professionals the option to prescribe things other than medicines and therapy. So putting people into social networks so that you can deal with the problems of social isolation, which we're increasingly recognizing as a major issue in terms of the burden of disease that it places on people. So again, some bit of a positive story here. I'm afraid there's then a collection of stuff, some of which is very popular at the moment, particularly around integration, where the evidence is a little bit more mixed, and this may reflect some issues about the difficulty of implementation. Let's talk about case management and care coordination, and typically what you see there is you should have a slide here with a triangle on it, where people will use a variety of methods, everything from asking the primary care team which patients they're most worried about, to a variety of quite sophisticated logistical regression type models, trying to identify the patients who are at highest risk. It has to be said that quite a few of these models still don't perform as well as they might. There's some issues here. The first is that the number of patients who are at very high risk is actually relatively small. In fact, we've shown 9% here, but in fact, the really high users are probably in the top 1%. And there's an interesting question about how much intervention can be done for those patients. The number of patients at high risk or very high risk actually is a fair number, but designing interventions that make a difference and proving that it works has proved a little bit difficult. And quite a lot of the studies, certainly that we've been involved in, have been frankly, a little disappointing. First issue is our old enemy, regression to the mean. The patients who are identified by these models are either dying or sometimes get better. So proving the impact of your intervention turns out to be quite difficult. The extent to which you have to redesign the whole care process to meet these people's needs, right, is very substantial. It seems it's quite difficult to hence the emergence of these extensivist type models. It's quite difficult to get a situation in which the you redesign the primary care and some of the specialist care in a way that can respond to these patients. And you need patients who have capacity to engage. Unfortunately, quite a lot of the patients in this top 30-odd%, a substantial proportion of them also have cognitive impairment, which is one of the reasons, of course, why they're at risk in the first place. So you've got to have quite a big impact on this at-risk group to have an overall risk impact. Oh, I've got feedback here. You've got to have quite a big impact on this group to have an overall impact on the system. And one very depressing finding from quite a few of these studies is that you may well, when you implement them, find that you do indeed prevent the admission of many of these patients. But there's quite a lot of other patients sitting in the emergency department or in the medical assessment unit, if you have one of those for the management of acute medicine, who are also quite legitimate for admission. And what we found is you displace these patients, these high-risk patients, and if you're not very careful, the hospital will fill the beds that you vacated with other patients, and the admission threshold falls, and you cannot see the impact of these schemes at a population level. You can demonstrate they've impacted on individuals, but the rest of the system has sort of responded, and our old friend Romer's law, a bed built is a bed filled, will kick in if you're not very careful, and the patients you displace through these risk stratified models will be replaced by others, so your total cost may have risen. We'll come to that. The other, I'm just going to go back, if I may, I'll go back to the slide with mixed versus may cost more. I don't know if whoever's operating my slides or whether you can see those. Hopefully you can. Just a few others just to pick out here. Quite a lot of home care schemes work well. Various types of hospital at home and intermediate care. Various types of shared care work well. Again, the design and execution of these seems to make the difference between whether they save you money or not. Just pick out one here that's perhaps slightly unusual compared with some of the others. The development of shared decision making, particularly for those categories of treatment which the Dartmouth folk, Benberg and others describe as preference-sensitive conditions. In other words, understanding the preference of the patient can be a very valuable part of the decision about whether to operate. So benign prostatic hypertrophy using transurethral resection of the prostate is the poster child for that. But similarly, hip replacement, knee replacement also seem to be areas where giving patients really sophisticated decision tools make a big difference to the type of decisions that they make. And in a study in a General Health Cooperative in Seattle, they found that the deployment of these reduced hip replacement by 26% and knees by 38%. I think a caveat here, though, is these are really useful methods for making sure that you get the outcomes that matter to patients. It is not the way to sell them to say, if we do this, we will save money. I think that's almost guaranteed to put everyone off, and in particular the clinicians. By the way, despite those very big reductions in operations, the costs only fell by 12%, which is great, I'll take 12%. But of course, those patients still did require ongoing management. And of course, some of them will have progressed to having surgery at a later point. So you may save money initially. It may also mean they don't have to have a revision because you've operated later in life. So I think the argument for shared decision making is this is ethically the right thing to do. It's likely to improve the cost effectiveness of the treatments we give and improve the outcomes that we get. But don't, for goodness sake, start the argument with this will save us money. Partly of which, in some cases, it may not. Patients may make other choices, although they do tend to make more conservative choices than the surgeons and proceduralists that they tend to see, regardless of whether or not there's a direct financial incentive for the proceduralist in the system. So it isn't just market mechanisms here. A few other things just to pick out. On various types of, we have NHS 111, which is a telephone bureau using algorithms to try and suggest to patients that they might take other choices than go to the emergency department. Quite hard to get that right. The algorithms tend to be risk averse. There are some early experimentations of using more sophisticated algorithms, indeed using various types of machine learning and artificial intelligence to do this. So I think this might be an intervention whose time is coming, and perhaps if more closely attached to primary care and hospital services rather than being a standalone service on its own, perhaps related more to the ambulance service, does offer some prospects to mean that we can at least direct patients into the most cost-effective bit of the system and most appropriate bit of the system to deal with their needs. Just one other little natural experiment we've had in the UK is in England. We introduced a whole range of minor injuries and walk-in primary care services with the intention of reducing emergency attendances in accident and emergency departments, our EDs. There's very little evidence that it's had any effect on the busyness of the emergency departments, but it does seem to have massively increased the use of these types of services. It is a fantastic example of supply-induced demand, while in Wales and Scotland, two other parts of the UK, who didn't do this, they've not seen the same increase. So it does, there's a really sort of reverse of what we've seen in these other services where people have been trying to reduce demand and actually have managed to end up increasing it inadvertently as an unintended consequence of a not very well thought through policy. Similarly, the attempt to try and introduce an administrative layer between a referring doctor and a specialist appears to have added cost, introduced delay, and is another example of an intervention designed to reduce costs, which has the effect of increasing it, which is interesting. There's a bit of a presumption in our system that people who have high referral rates should bring their referral rates down to the rates of lower referrers. No one ever seems to ask the question, should the lower referrers be referring at a higher rate? And there's a bit of an assumption that the average or something a bit less than the average is the right rate. And there's not a sophisticated enough analysis about why is it that some doctors refer more of some types of case. And there's again, we haven't time for it now, but it's quite an interesting and extensive literature which requires a more sophisticated understanding than what we've seen before. So if I now move on, I've got a little slide with a picture of it, of what looks like a swampy marshland, which is the real world. I hope you can see that. The real world of our interventions are designed often based on fancy hypotheses, but when they hit the real world, things get a little bit more difficult. And the next slide gives a bit of a feel for just a few of the things that you have to think about when thinking about reducing bed use. One of the, if we have time for this, we might come back and explore this, but I'm afraid that we too often see models framed on the basis of hunches and ill-formed hypotheses with faulty logic models in which the connection between the intervention and the desired outcome is not sufficiently evidenced, causally weak, and frankly a bit often a bit flaky. But as this diagram also shows, the number of things you've got to get right across a system and at different levels of the system is really quite substantial. And the number of things that moderate that and potentially get in the way, if we have time, we'll return to. But are very significant. And again, quite a lot of this does come down to issues of behaviour. Some of the most difficult issues are those situations in which the savings made from an intervention appear in another part of the system or in a different time period. And very few health systems I've come across have really managed to cope with interventions that save money in someone else's territory, being able to repatriate the savings adequately. It's particularly a problem in public systems like ours here in the UK that work on a sort of annual budget cycle, which makes the savings difficult to repatriate, particularly if they happen in subsequent years. So I'm going to go on now. I've got a little, I'm going to skip on, which says, why is it so hard to release savings from shifting care? One of the, I have a bit of a bee in my bonnet about the way that quite a lot of journals and research reports deal with cost. And in particular, there's a bit of a tendency to be rather cavalier about what is fixed, semi-variable and variable. And the definition of costs used in many studies does not really translate into the language of costs used by people who actually run hospitals. So we say we can save an admission, which will save us, say in our system, £2,000 or £1,500. The presumption is that is a saving that is available for reuse in the rest of the system. Now, in a world in which the system does not have to worry about the fixed costs and overheads of its providers, then that's probably quite legitimate. But in a world in which you're effectively a monopsony buyer, you probably do have to pay some attention to what is happening to the cost structure of the people who supply you. As you all will all be aware, the hospital costs are lumpy. They come in chunks, and it's a very substantial amount. And it's surprising how little we know about this, but a very substantial amount of this is semi-variable or fixed. And there's in many hospitals, a lot of the services are also indivisible in the sense that if you need an on-call surgeon and an on-call anesthesiologist, and they come in units of one, marginal reductions in levels of activity of patients in hospital or numbers of admissions makes zero impact on the fact that you need one. And as the workload expands, you get to a point where you need two, and again, you need two. It's quite hard to divide them up. They tend not to come in divisible units because you have to have many of these services there. So we take all of these fixed costs and all these semi-variable costs, and we apportion them, very often using formulae like numbers of patients, square meters used, footfall in outpatients. And so a very substantial amount of what we think is the cost actually is really completely inelastic in the face of changes in activity. And yet we continue to report the effects of interventions as though all of those costs were fungible, that all of the fixed costs can be shed, and that we can treat the stranded costs that providers are left with when you take work out as though they were not a problem. Now, in a situation where your problem is the hospital is full and need more activity, it's not unreasonable to say, well, the full cost is actually the metric we could use here, because we would have to probably build and create large amounts of overhead. But I think we see a lot of these schemes and a lot of these ideas distorted by what tend to be either misunderstandings about which costs are flexible, or worse, decisions based on allocation decisions made by accountants about how they've apportioned overhead. And this leads us to a real problem. So the important point here is that quite a few of these community services do not necessarily lower costs overall for the system, and I'll talk you through that in a minute. And some of the care coordination schemes can actually cost more than they save, partly because of the supply-induced demand problem, and partly because when we target overuse, we often discover undiagnosed disease that we then have to do something with. Just have a slide here that's labeled payer versus system impact. Just give you a bit of a feel for what I mean here. So let's assume that we take out a patient from the hospital who's occupying a bed and can be cared for elsewhere. Good for the patient. You get very serious muscle loss and other institutionalization problems from being in hospital. We take them out. That was costing the payer in our system around £1,400 a week. I might be able to buy, I'm lucky, a care home place for that patient at £800 a week. So I've saved £600. Well, yes, but if the costs are fixed and I'm the major purchaser from that hospital, then the cost to the system have actually gone up now to something more substantial. There's a typo here, so my numbers aren't quite right. I think apologies for that, but you get the idea. I've now got to pay the fixed cost of the hospital. Actually, I think this would be right. The fixed cost of the hospital plus the cost of the care home, which is a very substantial amount of money. That number is correct. Now, I could assume that the payer doesn't need to worry about it. Well, but it's a real cost, and someone's got to find it. That what often happens though is now that bed is free, more patients will be admitted. So the cost of the payer is now the cost of 2 additional admissions plus the cost of the care home bed. Now, the attraction of this is, and I think we've all got ourselves into terrible trouble in this, is that the average cost appears to have fallen. You can do the maths here, it's pretty simple, but I've got more patients through the system. But the problem is the total cost has risen. And for most of our systems at the moment, the problem is the total cost. That's the thing that's killing us. So there's a real problem about the way we've approached asking ourselves which costs are relevant to decision making here. And while it's great for a journal article to say drug X saved the system 1,000 admissions times £2,000 an admission, that's not a relevant cost if you're a hospital finance director or a chief operating officer or hospital director. So I think there's a really interesting problem here. It only matters if, one, you can shut the whole hospital, turn it into a housing development or retail park, and get rid of all those fixed costs. Or your problem is the hospital is full and you've got to create new capacity and you want to do that without building, in which case the cost calculus are different. So we have a sort of not asymmetrical cost function here, and the question is, where are you and what are you trying to achieve? And we've not helped people by the way that we've addressed this. So this suggests that some of these economic benefits will only be visible when we have a whole system change, and that in many cases, if you want to get this, we probably need to be more radical. And the criticism of many of these schemes that I've been running through is that they're too small, they're too underpowered. In fact, some of them were described by a colleague of mine who evaluated them as almost homeopathic. And they're not supported by wider system redesign and change. And the other thing that we are is massively impatient. So I think the principle that these models represent the future of healthcare is pretty much unarguable. But we need to be much more sanguine about what we think about whether they save money. We need to be much more careful about how we design them. I think we need to be more rigorous in the design, and we more to recognise just how hard this is, and in particular the extent to which some of this transformation is hard work, which will need double funding and double running, and that we've been massively impatient. And you see this in our approach to evaluation, where very, very frequently evaluations are done which are too short, done too early, and have failed to truly capture the active ingredient, which very often is not just the technical design of these programs, which is hard enough in itself, but also a change in the way that people practice medicine, practice nursing, a change in the way they relate to each other as professionals, and a change in the way that they relate to the patient as an active participant, which is often a requirement of these types of models, which is a very long way from where we are now. And I think we've massively underestimated the sociology that underpins these models and in our focus on their technical design. And at that point, I will stop, and I think we have some time for some questions. Thank you very much.
Thanks very much, Nigel. And for people I think who are furiously trying to write notes, the PowerPoints will be posted on the website, as well as a link to the recent report which came out from the Nuffield Trust. But we're open now for some questions, which I welcome people who are at the particular mics who might have particular kind of questions in regard to Nigel's presentation. And so we just have one on the mic over here, Dr. Swan.
Thanks very much. A very fascinating review, and troublesome, obviously, when we look at so many of these issues from a very black and white lens. Scope of practice, I think you're alluding to it. We're increasingly looking at nurse practitioners taking over more of physician roles, both in and out of hospitals, in and out of the community. Presumably, it's also possible for regular nurses to do more, to take more roles, more expanded roles in a lot of the care services that we see physicians currently taking on. Surely there's some research there, and I noticed that the IHE is looking at cost effectiveness of nurse practitioners, which is welcome. What have you found about expanded scope of practice? And now we have pharmacists in Alberta taking on a stronger role. Do you have any comments?
Yes, in fact, we have a parallel piece of research on expanding skill mix we've looked at everything except medicine, and you're absolutely right. The scope for nurses, pharmacists, physiotherapists, and a range of other professionals to paramedics, we mentioned as well, to take on a range of jobs that are generally done by physicians, particularly what we would call the sort of middle grade, the sort of trainee level of physician. There's a great deal of scope. I mean, just a few things that are worth saying is that it does take a long time to train them. At the moment, in Europe at least, we don't have recognised training that makes these qualifications portable, which is a bit of an issue. So there's a sort of national policy question there about making sure that as we train people, that we regulate them. What physicians' assistants in the US are another example of this, which is we've imported them, but we've run up against a problem, which is our regulatory environment at the moment hasn't caught up with that, and they're not allowed to prescribe, even though they're perfectly capable of doing that. In primary care, again, we've seen a lot of good examples of substituting nurses for doctors. The patients, once they get used to it, very much appreciate it. They actually often score the nurse practitioners more highly than the doctors. And here's a rub. We think one of the reasons for this is the nurses are more thorough and they spend more time with the patients. So unfortunately, the saving that you make for the fact that the nurses are paid less than the doctors is to some extent offset or even written off by the fact that they tend to take longer to do the tasks and they're less flexible. But given that in much of the developed world, our problem is a shortage of doctors, actually, this is a great way of providing clinical professionals with ways of expanding their scope of practice. So yes, and pharmacists is the latest addition, and they can manage a caseload as well as the type of interventions we were talking about in nursing homes on prescribing can be very effective, and you'll find that in a parallel report that we'll do that we can make available.
Could I just ask a follow-up?
Yeah.
Can you make a comment about how you pay physicians there? Are they all on salary, the family physicians in particular?
No. So hospital doctors are on salary. We have a parallel private practice market, which is a slight complication, but they are paid salaries. And family doctors are as a combination of family doctors paid by salary, but as employees of other family doctors who run basically for-profit partnerships in which they're effectively paid they're paid a sort of mix of capitation, pay for performance, and a small amount of fee for service. But there's very, very little fee for service medicine in the NHS, in the state side of the health system in the UK. And that pattern, Spain and Italy have GPs who are salaried, but the model of family doctors on some form of self-employed contract and some type of salary or retainer model for hospital doctors is a common model across Europe. And I think I think I've forgotten the name of the health economist at Berkeley. He says the three worst ways of paying doctors are salary, fee for service, and capitation. It's just, in other words, we haven't found a good mix. We haven't managed to titrate quite the right mix of how we pay our physicians in our system either.
Thanks very much, Nigel. I don't know if there are other questions. I did have one, because I know the focus a lot is on as we shift things out of hospital into community-based settings, and the two key areas I guess are avoidable hospital admissions as a key part where you might save money, or be able to have earlier discharge for patients into community-based settings. And I'm wondering if you had comments on which one of those, they're both an important focus, but which one from your experience is one that might lead to enhanced cost savings in the system?
Well, that's really interesting. Yeah. So in our system, I'm going to have to turn the volume down. In our system, we find that a relatively small number of patients who stay more than 7 days account for a very large number of the hospital bed days. We have a higher, from the international comparisons I've seen, we have a higher proportion of patients who could be cared for in other settings in our hospitals than you do from the studies I've seen in Canada and the US. The advantage with those patients is we do know who they are and we know where they are. And we've got a fair idea about the type of interventions that they need to be able to move them, whereas preventing admission prior to the patient presenting requires, as we saw from that triangle, having to dissipate quite a lot of activity across a large number of patients, many of whom may not have been at risk of admission in the first place. We've had some success of turning patients round when they get in the front door. So hence the idea of having very senior decision makers who've got access to immediate home care. In terms of resource release, I think opinions seem to differ here. My personal feeling is we're in a position where there's still more to do to get patients who've been admitted out more quickly. And we've seen a big growth in the treatment of quite a lot of emergency internal general medicine on an ambulatory basis. So things like pulmonary embolus and deep vein thrombosis, cellulitis, conditions that need IV bound. Don't let the patient get undressed. Don't put them in a bed. Have them out the same day, and we've seen a huge increase in that. And for quite a lot of these patients, keeping them out of hospital, that initial keeping them out, does seem to pay big dividends in reducing the risk of hospital, what's it called, post-hospital syndrome, or institutionalization, muscle loss, and risk of chest infections and other hazards of being in hospital. But I honestly am not sure we fully know the answer to that. My suspicion is in the UK setting, getting patients out quicker is still the place where it's going to be easier, and there's an easier win, and the numbers are bigger.
Okay, thank you very much. I don't know if there are any questions from the rest of the mic. There's just one, Dr. O'Neill.
Thanks, John. I enjoyed your presentation. I think one of the challenges you have identified for us is the fact that we do a lot of initiatives, but we're challenged to find those so-called hard green dollars, and you sort of explained, I think, very, very clearly why that is, the amount of fixed costs and semi-variable costs that really make it hard to move the dial. Well, the question is, have there jurisdictions that have got the whole system right, that have managed to squeeze those hard green dollars out and really move the dial in a measurable way to achieve the kind of savings that you've talked about it being so difficult to achieve?
Well, it depends what we're trying to achieve here. So Germany do seem to have managed to stem the sort of almost inexorable growth in hospital admission that we've seen in quite a lot of European countries. I mean, and they've done that by shutting lots of hospitals. So Germany, in terms of numbers of beds per thousand population, it's still the case that Germany has probably got one and a half, 2 beds more per thousand population than the UK. So they've had some scope to do that. So they've had some success there. Greece, Latvia, Estonia. It's wondrous what a very heavy dose of very substantial financial austerity can do to your health system, and it's but not recommended in terms of health outcomes, I have to tell you. But that's largely been achieved by just shutting off the supply. I think if you look at the US systems that have done quite well here, Intermountain Healthcare, Kaiser Permanente, what they're doing, I think, is bending the rate of increase. I think that's and you see this in about 50% of the ACO pioneers, people have managed to bend the rate of increase, and I think that's an achievable goal. I think what people have really struggled with is to say, well, if we start with where we are now, can we actually get an absolute reduction? And that's short of the IMF in your finance ministry telling you to take sways of cost out of your health system. That's proved very, very difficult to do. But certainly some of those big ACO type systems that have done well and started from a good base in the US do seem to have had success in bending the curve. And I wonder if actually in many senses that's the sort of policy objective that most health systems probably want to aim for anyway.
Okay, thanks very much. And thanks so much, Nigel, for staying up and sharing with us. And we'll sure to be in touch with follow-up activity. But please join me in thanking Nigel for participating today.